Hello, can you see my screen?
Yes.
Okay. Yeah, thank you very much for your kind invitation to talk on RVOT stenting in neonates with fallow-type lesion, technical consideration, and equipment preferences. Sorry, I can't. Oh, here we go. Advance the slides. There are no disclosures related to this talk whatsoever. I'm just a poor pediatric cardiologist from the UK. Now, RVOT stenting we introduced in about 2005, and it has become our principal technique in the management of fallow-type lesions in the initial palliation. And certainly in the UK, neonatal repair of tetralogy of fallow remains the exception. We use cardiac ultrasound to assess the intracardiac anatomy, subcostal views, parasternal short axis views. And I think cardiac ultrasound is really the best technique to look at the infundibular pulmonary valve, branch pulmonary arteries. Unless cases with MAPGAs, so pulmonary atresia, VSD MAPGA, or extreme fallow with MAPGAs, we would not do a CT. If we then make a decision this child needs in initial palliation, mostly because of history of spells or comorbidities, then we would prepare for cardiac catheter, normally from right femoral venous approach, biplane angiography in the right ventricle through either an NIH or Gensini catheter. My preference certainly is for 30 REO and 20 cranial because that aligns the outflow tract. And having said that, you still get foreshortening, so trust the echo with regards to length measurements. And equally, sorry, on this subject, if you measure an RVOT stent, especially if you work valve sparing, to be, I don't know, 14 millimeter, always go for longer, 16 or 18 millimeter. Angio will always foreshorten. And I use straight lateral, especially to profile pulmonary valve angles. We select some reference images. And then if we decide to proceed, we withdraw the catheter back to the right atrium. And we prepare all the kit we are likely to use. So we leave the wire in the SVC. I always use a long sheath. My preference again goes for 4 or 5 French Cook flexor sheaths, braided with a marker band. Sometimes I use 23 centimeter radial sheath, but the downside of those is that they don't have a marker band. And in some cases, we use a short guide catheter, 6 French RJ, and we can use a 4 French right Judkins through there. Some people use Terumo destination sheath, whatever you've got, really, and are familiar with. Rationale behind long sheath, and for my opinion, is really it's less traumatic. You don't have a stiff wire going through the tricuspid valve, which is at systemic levels, and doing damage to the tricuspid or AV valve is very bad news. You get more stability, you protect the wire, and stent delivery is certainly much smoother. Equally, you can do sidearm injections throughout the procedure, and there's no need for a second cath. Finally, I think long sheath facilitates balloon wire removal, and it also reduces risk of stent embolization when retrieving the balloon. So once we place the long sheath in the IVC-RA junction, and you see that on this lateral view, the tip of the long sheath is really there below the diaphragm. Enter the infundibulary, ideally with the diagnostic catheter, right Judkins, normally either 4 or 5 French, the same size as the long sheath. We enter the infundibulum, look at the pressure, that we don't get an injury pressure when touching or being in the myocardium rather than in the lumen. And then we do another test injection. And then ideally we cross the valve directly with the catheter, otherwise with an angled Terumo 035. If the stenosis is severe or there's atresia of the pulmonary valve, then we may need 2 wires, pro-grade CTO wire, or even pulmonary RF perforation. And it's really like the excellent talk by Masny, you have to think pulmonary atresia intact septum. to do some of this work. Then when we cross the valve, we advance the right Judkins to the RPA, and over this right Judkins, we advance the long sheath. So use the right Judkins more or less as the dilator for the Cook flexor sheath or Mullins, whatever you use. And then we remove the RJ and tumor wire, and we place appropriate wire for a stent as distal in the RPA as possible. Now, I was asked frequently as to whether patients tend to spell once you're in the infundibulum or across the valve with the long sheath. In my opinion, it's really quite safe because you push away the anterior deviation of the infundibulum, and they don't spell. They spell during trying to enter the infundibulum, but not once you're across it. And yeah, for coronary stents, we would use 014 wires. I prefer through-way wire, which is fairly stiff, but has nice distance markers also. Choice PTX to support. I would strongly advise against using hydrophilic wires with the flexor sheath because they work together, and normally the wire actually gets extruded. Oops, sorry. BMW wire, in my opinion, is not stiff enough. You may get away with a long sheath. And for bilirubineal stents, I would normally use a Cook formula 418, and that goes nicely on 014 wires. Otherwise, wires as suggested. So during stent placing, we basically do multiple sidearm injections. In my opinion, it's a one-person responsibility. So once your wire is in distal RPA and nobody touches the wire, possibly put a wet swab on it that it doesn't work itself out, you can pull back the long sheath, and then the left hand holds controls the balloon and the stent position, and the right hand inflates. There's no need for an indeflator. And when I place the stent, then normally what I do is once it engages, I push forward with my left hand so that the stent moves away from the tricuspid valve. One-person procedure. Sorry, next one. And then I try personally to avoid the pulmonary valve, especially with anomalous coronary arteries, or if the patient needs a conduit later on anyway. But I would always dilate the pulmonary valve. If I spare the valve, I normally use a bigger stent to start with. And then once the stent is in, we deflate the balloon. I then normally try to touch the stent with the long sheath and really try to re-sheath the balloon with the long sheath. We stabilize the stent in the RVOT. And ideally, the long sheath should be within the stent at the end of balloon retrieval. Then we do another sidearm angio through the long sheath and do a cardiac ultrasound, epicardial, precordial, subcostal, and really double check that the proximal RVOT is covered, that there's no effusion TR. Normally we do another gas, possibly wait 10 minutes and then really extubate the patient on the table. It's very rare that we have to go to ICU these days. We always start diuretics if the increase in saturation is more than 20 points or something like that. Stent selection is really dependent on age and weight, clinical condition and context. So a neonate weighing 2.5 kilogram and above, I would probably go for a 5 millimeter stent. If you want to valve spare or you do valve spare, again, 5 millimeter stent, 6 millimeter stent. I think coronary stents really only in small neonates. Otherwise, I would go for a balloon dilatable stent later. You have to consider the length of palliation required, and that also will depend as to whether there are comorbidities, whether there are associated lesions, MAPGAS, AVSD, double outlet right, and so on, where we want to buy longer palliation. And it's also a question or there's a number of patients, late presentations, especially in India or Southeast Asia, and I think RVOT stenting in those really very, very hypercyanotic late presenting fellows is very rewarding. And there one should place the stent by 10, 15, 20 points in saturation, possibly come back a couple of weeks later and make it bigger before referring for surgery. Stent choices, as I said, bare metal coronary stents, 3 to 5 millimeter, 5 would be my preference really. The problem with bare metal coronary stents is that the adults don't use them anymore. Most centers actually don't have them on the shelf anymore. And equally, the material got thinner and thinner. So I'm a bit worried about this development. I'm quite sure people using drug-eluting coronary stents, I don't know whether there is any real benefit in it because, yeah, it's tissue ingrowth rather than neointima. And my preference certainly goes for Cook formula, which is a biliary stent, which we can dilate quite nicely. The downside of the Cook formula is really that it's not very conformable to the anatomy. You end up with a rather straight, stiff pipe in there. Boston OmniLink is more conformable. Cordis Genesis, I personally don't use value. Covered stents, I think the Bentley graft, it looks very attractive and maybe easier to retrieve surgically later on. Biodegradable stents, personally, I don't think they will have the strength to last the course of palliation, so I wouldn't use them at present. So in conclusion, RVOT stenting in fallow-type lesion has become an accepted and reproducible procedure, first choice in the initial palliation. I think the use of a long sheath is key to success and reduce complications. And stent selection is very dependent on clinical context. Thank you very much for your attention.